Hello, guys. Let me know in the chat box. Am I clearly audible and visible to you guys? Let me know in the chat box. Am I clearly audible and visible to you guys? Let me know in the chat box. Okay, I can see over the chat over the screen. Let me know in the chat once, guys. I'm waiting for your answers. Let's start the session, part 2 of ophthalmology, right? As you all guys requested for the part 2, right? So we planned for the part 2, and today is the day when we are doing this part 2, right? Near to the exam for your last 25 days. And of course, we're going to cover up most important topics, right? Most of our important topics, which have the high yield, which is can come up, right? So already we had the part 1. I hope you watched that session, part 1 session. And we are going to do this part 2 session also today, right? So just let me know in the chat box once. Is everything is okay? Audible, visible, everything is perfect? Then we'll start this session. I'm waiting for your response, guys. I'm waiting for your response. Just waiting for your response, guys. Let me know in the chat box. Okay. I'm getting okay, right? Okay. Let's do start this session. So this is the part 2 of the ophthalmology session. Just my request to you, if you are new to here, right? If you are new here on this channel, so please watch the part 1, uh, which is the previous one. Just attend now the part 2. And of course, I recommend to you, check the part 1 also. If you are going to do this, all the 2 parts of the important high yield topics of ophthalmology, it will be going to cover up your all the summarizing and it is completing your all the important topics related to your exams, right? So please try to finish the part 1 also if you are new here, okay? And if you already watched the part 1, let's start the part 2 also here. All right, so yes, doctor. So let's start. uh, just a minute. Let's start this session. Let's start the session, right? Okay, so let's everyone will join the sessions. I'm waiting for you, all of you guys only. There was a little bit delay, so I think you will join soon, right? Okay, let's start up with the second session. And again, the same scenario will as we had the in the first session. First, I will going to show you the MCQ. You have to answer that MCQ, and after that, I will be going to take up the all the options and the your explanation of that particular topic, right? So let's start this session. And we had already 8 MCQs in the part 1. I hope you remember that. So I'm showing you the last MCQ which we had in the part 1 session. I hope you remember that. If you didn't join that session, if you didn't had that session, please, my request to you again, please watch that session after this session, okay? So this was the last MCQ which we had. Okay, now moving forward for the next MCQ. Before the starting it, as we are talking about the your conjunctiva topic, right? We was talking about the your conjunctiva topic. So one more topic is there which is related to your conjunctiva, right? Which is your fictanicular conjunctivitis, right? Which is your what? This is your important topic which is known as your fictanicular keratoconjunctivitis. We had talked about the VKC, vernal keratoconjunctivitis. We talked about the vernal keratoconjunctivitis in the last part, right? So now we have to talk about the different type of the conjunctivitis. So we are talking about the first one, which is your fictanicular conjunctivitis, right? So what is the features of this fictanicular conjunctivitis? Let's talk about this. What is the features of here about your fictanicular conjunctivitis. So let's start up with the first one, that the fictin is what? Please remember, underline this thing, which is a very important. What is the fictin? The fictin is your pinkish whitish nodule, which is 1 to 3 mm of the size, right? So you can see up here this nodule, which you can see up here, right? This nodule is known as your flictin, right? So this nodule is known as your flictin, right? This is just 1 to 3 mm, right? And this is surely surrounded by your hyperemia. Guys, underline this key features. So it will be going to help you when you are going to see the clinical case scenario related to this particular this MCQ, right? So please check up this about it, that this is about your pinkish nodule. This is a pinkish whitish nodule, which will be 1 to 3 mm of the size, and this is surrounded by your hyperemia. What is the mean of hyperemia? I hope you can see up here. There's a totally hyperemia. It means the blood flow will be increased there. So you can see this is the redness, or hyperemia is the near surrounded here. Yes, I hope you can see up here, right? So this is surrounded by this hyperemia, and where it will be going to see, of course, it will be on your bulbar conjunctiva, right? So it will be not on the palpebral. What is the palpebral conjunctiva, guys? The palpebral conjunctiva, which is beneath the eyelids, right? So this will be not there. It will be where? It will be on the bulbar conjunctiva, and yes, bulbar conjunctiva, which you can see clearly, right? Which is covering your scleral part, which is going to cover your scleral part. So now this fictin. Now what has happened? This fictin is usually seen near the limbus. I already told you what is the, guys, limbus. This is the limbus, right? This is the limbus. And what is this? This is the junction between what? Cornea and sclera. Yes. So the junction between cornea and the sclera, this is known as your limbus. So it is surely near the close to the limbus. So you can see this fictin is near to the close to the limbus, right? So this is a fictanicular conjunctivitis, fictanicular keratoconjunctivitis. The name is fictanicular keratoconjunctivitis. Now, what will be the your here cause? So please remember, it will be your delayed type of hypersensitivity. We talked about your vernal keratoconjunctivitis, that is the type 1, which is the acute type of conjunctivitis, your hypersensitivity. But if I'm talking about here, it is what? It is your delayed type of hypersensitivity. And which type of delayed hypersensitivity? Of course, you know about it. This is your type 4. Type 4, which is your cell mediated. I hope from your pathology knowledge, you know about the types of hypersensitivity, right? All the 5 type of your hypersensitivities, you know about it. So this is your type 4 delayed hypersensitivity. Now, if I'm talking about the causes, so what will be the cause here, guys? What will be the cause here? If I'm talking about it, the cause will be in this condition. We're going to see here that the cause will be here the tubercular, it means the TB, and the streptococcal, which is the most common cause. So I'm clearing you here only your doubt. What is the mean by the tubercular? This tubercular will be going to seen in India, and your streptococcal will be going to see the worldwide. Yes. So if your patient is having the TB, right? The fictanicular keratoconjunctivitis, the most common cause in India is your TB. But if I'm talking about the worldwide, it will be your streptococcal. It will be your streptococcal, right? Streptococcal. Now, this will be seen in the more commonly seen in the girls than the boys. Just opposite of your VKC. In the VKC, what we find? Yes, in the VKC, we find that is seen in the boys, right? That is seen in the young boys. But what about it? What about it here? No, it will be going to seen in the. It will be going to seen in the your. Yes, it will be going to seen in the girls. Very good, right? So this will be seen in the more commonly seen in the girls than the boys, and this will be where between girls which is having the age between the girls which is having the age between the 3 to 5, 3 to 15 year of the age, right? 3 to 15 year of the age. Now, this is all the features which I talked about here till now. This all are on the conjunctiva. But sir, as the name is saying here, carato, carato it means the cornea, and conjunctivitis it means the conjunctiva. So it is involving the carato, it means it involving the cornea also. Yes. So what can be happen, guys? Please listen up this part. If this ulcer or this pinkish nodule which is over the your conjunctiva, if it is increasing in the size, I hope you can see up here, if it is going to increasing up in the size, and maybe if it is covering, maybe if it is covering the your corneal part also, if it is overlying or it is overlapping your cornea, that will be known as your fascicular ulcer. That will be known as your fascicular ulcer. Yes, so I hope you can understand it up now, that if it will be going to cover up, not like that the simply, right? If it will be going to start growing up and it will be going to cover up your cornea also, that then it will be going to known as, then it will be going to known as your fascicular ulcer, or we can say the miliary ulcer also, right? So this is the known as the fascicular ulcer or the miliary ulcer, right? So this is the fascicular ulcer or the miliary ulcer. Now, if I'm talking about it, if I'm talking about it, that what will be the our treatment part? So in the treatment part, please remember we have to give for the ocular, for the, please remember, for the ocular symptoms, we just give the topical steroids in this patient, and we have to treat the causative treatment. Like I told you, in India, like in India, we have causative organism is TB. So we have to start the ATT. Yes, of course, we have to give the antitubercular treatment. And if I'm talking about the worldwide, there will be the streptococcus. Yes, staphylococcus is the your cause. Staph is your cause. So of course, we'll add the antibiotic. Yes, of course, I will be going to cover up here with the antibiotics also, right? I have to prescribe to this patient. I have to prescribe for this patient antibiotics also. With the steroid, I will be going to add on here. I will be going to add on here with the your steroid. I will going to add on here antibiotics also, right? So this will be the our treatment for this fictinicular conjunctivitis, fictinicular keratoconjunctivitis. So please remember, keratoconjunctivitis means the kerato, it means the cornea will be also going to participate here. So keratoconjunctivitis will be the fictinicular keratoconjunctivitis is the full disease, right? So it is a quite easy disease. Maybe they can ask you about the treatment or maybe the causes. So please remember, the India is the most common cause of, in the India, it is your TB, tubercular, and the worldwide, if they are asking you, then it will be your staphylococcus, right? Very good. Let's move forward. Let's move forward for the next. And the next question I'm showing you in front of your screen. I hope you will be going to reply in the chat box. Who guys are watching live, please listen up this question and check the image based question, right? This very good question. What is the diagnosis, what is the diagnosis of the lesion is given image below. So this is the image which is given below. So you can see up there, and they are asking you about it. They are asking you about it, that what is the your diagnosis in this case. So the options are given here. Fictinicular keratoconjunctivitis, just now we covered up there. The second is the talking about the bitot spot. The third is the your pincula, and the fourth option is the D is your pterygium. So guys, I'm waiting for your answers in the chat box. Please, who guys are watching live, please try to reply your answers. Please try to reply your answers in the live chat box, guys. Please try to reply your answers in the live chat box. I'm waiting for your answers, guys. Who guys are watching live, please reply. Very good. I'm waiting for your answers. Just check out the image. Just check out the image. What you can find is it the fictinicular conjunctivitis which I shown you just now? Is there a fictan, which is the nodule? It seems you on this image? No, there is a no fictin. I cannot see there any your nodule structure. Yeah, nodular structure I cannot see. So the option A is the not the possibility for it. Yes, I cannot say. Of course, the hyperemia is a little bit going to seen, but it is not the nodule. It is a wing-like structure. It is not the nodule. It is wing-like structure. The option B is here given to you, your bite or spot. Guys, I hope you already know about it. We covered up that what is the mean of bite or spot. It is not the possible, because bite or spot is totally seen on the totally seen on the your conjunctiva, and please remember it is your whitish color. Yes, white in the color and the foamy. Yes, in a foamy, it is a in the shape of form, right? So it is a foamy. Biter spot will be your forming shape, which is on the your most commonly seen in your conjunctiva. In the your vitamin deficiency, right? Vitamin A deficiency. Now, if I'm talking about the pingacula or the pterygium, the option which can give you guys when we confuse here, it can be or the only the two, the pingacula or the pterygium. So, guys, please remember about it. Please remember about it. It cannot be possible the pingacula, because this pingacula is also a nodular structure. Yes, it is also the nodular structure, but I cannot see any nodule in this condition. So what will be your answer? Yes, your answer is your pterygium, because this is your wing-like structure. Yes, so you can see here, guys, clearly that this is the growth of the conjunctiva, which is having a wing-like shape structure over the cornea. Yes, over the cornea. The normally our conjunctiva is not covering our cornea. Yes, the normally our conjunctiva is not covering our cornea. But in the case of your pterygium, what is happening? In the case of your pterygium, it will be going to cover up. It will be going to cover up your it will be going to cover up your cornea, right? Now let's move forward. So answer should be here what? The answer should be here, correct answer is your pterygium. So let's talk about this. What is this pterygium? So this pterygium is the your under the not the infective conditions of the conjunctiva, it is your degenerative conditions of this is the degenerative conditions of your conjunctiva. So please remember, still we talked about your fictinicular conjunctivitis, that is your infective. Of course, the causative organism was your TB and your staphylococcus. Of course, in the VKC also that is also infective, because it is by the allergens, right? So that is also coming up in your allergic type of the conditions. Now we are talking about your degenerative type of conjunction. Now we are talking about the degenerative type of conditions, and in this degenerative type of conditions we are starting with the first one, which is your pterygium, right? We are starting with the first one, which is your pterygium. So you can see here it is your overgrowth. What is this? This is your overgrowth of the conjunctiva over the cornea. Yes, so this is the overgrowth of your conjunctiva, which is growing over the cornea. Now, what kind of this growth is it? So please remember, this is your elastotic degeneration. What is this? Yes, this is your elastotic degeneration with the hyperplasia of subconjunctival tissues, right? So I hope you remember about it. What is the mean of hyperplasia? Increasing the number of cell. Yes, hyperplasia, right? Or hypertrophy, yes, increasing the size. So what is happening here? This is making the elastotic degeneration of the with the elastotic degeneration of your conjunctiva. With that, there is a hyperplasia, increasing the number of your subconjunctival tissues in the form of vascularized granulation tissue. So what is happening behind between it, just what we have in the just below the your conjunctiva, we have the subconjunctival tissue. This will be going to do the hyperplasia in the form of vascularized granulation tissues, right? So you can see the vascular the vascularity is also will be going to seen here. This vessels which is passing in this pterygium is clearly visible to you. The next, what will be the causes here? What will be your cause here? The cause is your exposure to the ultraviolet rays of sunlight. It means it is caused by your exposure of your UV rays. It is caused by your exposure of your UV rays, right? And which UV rays? Of course, the sunlight UV rays. Not we are not talking about the artificial UV rays. We are talking about the sunlight UV rays, and this is due to the sunlight UV rays. This will be going to cause there, and That's why only this is the main implanted in the etiology. And of course, as it is by the sunlight, so what it will be going to see, it will be seen in your farmers and workers. Yes, workers who guys are working in the sunlight, right? So who they will be the more exposure, right? They have the more exposure of the sunlight. So due to this, there is a more exposure of in the farmers and the workers we are which are working in the sunlight, right? And that they are getting the this UV rays exposure. Now the pterygium is having the guys three part. Of course, they are asking you in the NEET PG and the FMGE exam also, right? What the parts of this your what's the parts of your what's the part of your pterygium. So the first, which is your head. So what is the head? I'm marking with the number one, labeling the number one, and you can see here the part which is growing forward, right? So you can see it is grown forward and reach on the your cornea. So this is the your head of pterygium. This is the your head of the pterygium. After that, you know about it. The after the just head, we have the neck, and just below the neck, we will be going to have the body. So this part will be going to known as the your neck of the pterygium, and this third part will be your body of the pterygium. So we have the head of the pterygium, we have the neck of the pterygium, and we have the body of the pterygium also. So please remember head, neck, and the body. Okay, so we have the three parts: head, neck, and the body of the pterygium. Now, why we have to talk about this? Because sometimes what is happening, there is a sometime there is a deposition of the iron can be seen sometimes. And where it will be going to seen? Of course, it will be seen on the your corneal epithelium. Yes, close to the head of the pterygium. Yes, it will be close to the your head of the pterygium, and this is the anterior to the advancing head, right? Is called your Stocker's line. This is your PYQ. So what is your Stocker's line? Just check it out here. Just check it out here. I'm erasing this all of this. Just check it out here. Near to this pterygium, you can see up here what can be seen. What can be seen? There is some iron deposition on the your head of pterygium here. The iron can be deposited here, and if the iron is deposited near the head, where in the corneal epithelium, please remember in the corneal epithelium, this will be going to known as your this will be known as your Stocker's line. Yes, this will be going to known as your Stocker's line. And of course, what should be now the treatment? Because this is the degenerative conditions, guys. So of course, there is a no medical management should be needed in the pterygium. What we have, guys, we have only the one option, which is your surgical removal. So what can be we can do in the treatment part of it? Of course, it will be your surgical removal of the your surgical removal of the your pterygium. So in the surgical removal of the pterygium, what if we do the surgical surgery, only we are removing it, and after the surgical removal there is a chances of the 30 to 50%. Guys, please remember, if I do the just the simple surgical removal, just write it down, simple surgical removal. If I do the simple surgical removal, what will be going to seen? There is a 30 to 50% of the chances are there that this particular pterygium can grow over it again. That is known as your recurrency of pterygium. That will be going to see the recurrency of the pterygium. Now, what we can do going to do this against this, because as we are not this is not possible if we are doing the surgery again and again, the 30 to 50% of the chances in the patient that it will be going to recurrency will be going to show there. So we have to stop this recurrency for the decreasing the recurrency. What we'll be going to do, we're going to do the conjunctival autograft. Guys, what is the mean of autograft? From the same person. Yes, I hope you know about it. From same person, we're going to take the conjunctival autograft of the stem cells, and we're going to implant over there, that it should be to avoid the recurrence. And of course, it will be decrease the it will be decreased near the just 1% of the chances will be left after the conjunctival autograft. Just 1% of the chances is left after. If I done the conjunctival autograft, just 1% chances are there that patient can get again the patient can get the again the your pterygium, right? So this is the all about the pterygium. Of course, what we'll be going to do, we'll be going to cut the conjunctiva from here. This is the surgical removal, and we're going to remove this which is part on your cornea. And of course, we're going to implant here. We're going to implant here or this autograft. Yes, we're doing the grafting of the same person's stem cells of your conjunctiva will be over the near the limbus only, and there will be the now it can be avoid the now it can be avoid the our recurrency of the avoid the recurrency of the our pterygium. Is that okay, guys? All right, I hope is it clear to you? Very well. Let's move forward. So this is the pterygium. Please remember, this is a very important topic. I'm making a star over here. You have to remember here. Now let's move forward for the next thing, and this is about your next question, guys. Please try to reply me in the chat box. Right, we are talking about the more important topics and the more important questions which is having the chances to come in your FMG exam on the 12th January 2025. All right, so now we are talking about the question number 10. Your 32-year-old female patient present with the history of eye trauma. And with the eye trauma, it is having with the what? Vegetative matter. Guys, this is the key point which I'm highlighting over there. So you have to keep your mind on this particular, all the key features, right? So there is a 32-year-old female is had the eye trauma with the vegetative matter, and now she complains of the severe eye pain. It is having the severe eye pain, having the redness and the tearing and the photophobia. So it is having the what? It is having the severe eye pain, redness, and the photophobia. Now, what is this condition? Is the most common causative organisms in this condition. So this is going to ask you, the examiner want to ask you about the what is the cause of this condition. So now I'm waiting for your answers, guys, in your live chat box. The options are given here. Option A, fungal corneal ulcer. Option B, bacterial corneal ulcer. Option C is your viral corneal ulcer. And option D is your acanthamoeba corneal ulcer. I'm waiting for your answers, guys, in the live chat box. I'm waiting for your answers, guys, in your live chat box. Guys, try to reply. No issues. If you are going to reply wrong or correct, I will be going to correct you, right? I will be going to correct you here, right? So just try to reply. Just try to reply, guys. What is your answer? Please mention in the chat box. Yes, guys. Very good. Very good, very good, very good. Now, yes, exactly. Guys, as you already know, it cannot be the viral corneal ulcer because it is your painless ulcer. Yes, it is your painless ulcer. And in the history of the patient, in the question only, they mentioned you clearly. They mentioned you clearly. The patient is having what? The patient is having the severe eye pain. So this is not the possible over this. Of course, it cannot be the your acanthamoebal corneal ulcer because here will be the history of. There will be given on the history of your corneal lens uses. Yes, there will be the corneal lens use or the misuse history should be given in the cases of your acanthamoebal corneal ulcer. So this two is ruled out. Now, the biggest confusion between the two, which is your fungal corneal ulcer and the bacterial corneal ulcer, both are having the severe eye pain, both are having the redness, both are having the features of tearing and photophobia also. But what is the key feature here which is going to separate this, right? So we have to talk about this particular feature, that what is the main key feature which will be going to separate this between the, yes, this will be going to separate it between the your corneal ulcer, your bacterial corneal ulcer or the fungal corneal ulcer. So guys, please remember about it. That is your vegetative matter. Yes, this key feature, which is the your vegetative matter, it will be going to give you the that this is the answer is your here fungal corneal ulcer. Because please remember, there will be the presence of history will be going to present of trauma with vegetative matter. Yes, there is a vegetative material should be there will be the presence of it. Of course, in the bacterial we don't need about this history of any trauma or whatever, right? The bacterial ulcer can be see over there, like the same question was given. If there is the same question was given over there and the patient is not having any history of the vegetative history, right, the trauma of any vegetative matter, so of course it can be, right, of course we have to diagnose it later also, right, with the some different. But if the question was given to you in the exam the same as it is which is showing you on your screen, and there is a no mention of the history of eye trauma with the vegetative matter, of course your answer should be the bacterial corneal ulcer. Okay, so by this word only, which is a key feature I already highlighted with the highlighter, and this is your vegetative matter. So you have to remember with this that if the vegetative matter history is given to you, if the vegetative matter history is given to you, you have to understand that this the patient is having the which yes patient is having the fungal corneal ulcer. So let's talk about it one by one, all the type of your your ulcers. So starting with the first one with the cornea. In the cornea we are starting with the first one, which is disease is known as your keratitis. What is the meaning of keratitis? Kerato, it means your cornea. Itis means the inflammation. So there will be the inflammation will be going to seen over the cornea. And please remember, if inflammation will be going to seen over the cornea, that is known as your corneal ulcer. That is known as your corneal ulcer. Right? Now, there is a we have the different type of your corneal ulcers. So we are starting with the first one, which is your bacterial corneal ulcer. And how we are going this classification of the keratitis, this is on the based on causative organism. If the bacteria is the causative organism of this ulcer, so this is known as your bacterial corneal ulcer, right? You can see over here. If your causative organism is the fungus there, it will be known as the fungal corneal ulcer. And if your causative organism is the your herpes simplex corneal ulcer, it is your virus. So this is caused by the herpes simplex virus. It is also known as the viral keratitis. It is also known as the viral keratitis. Okay, so this is also known as your viral keratitis also. And of course, if the acanthamoeba is the your causative organism, this will be the your acanthamoebal keratitis. The last one, which is your interstitial, if the in the interstitial space we have the keratitis will be going to inflammation of the interstitial space, that is known as your interstitial keratitis. So this is based on the your the four about the right. So this is the classified as the based on the your over the classified on the based on the your causative organism. Right, now let's move forward. Now we are talking about it. About the your next types of every type of your corneal ulcer or the keratitis. So one by one we are talking about it. So starting with the first one, which is your bacterial corneal ulcer. So starting with the first one, which is your bacterial corneal ulcer. And of course, you can see over this image, guys, what you will be going to see over this image. I can see up here that on the cornea, I can see one growth over it. I can see over the cornea one growth over of it, and this is what not that we can say the growth. It is kind of a ulcer which will be on the your cornea, right? We can see up there. There is an ulceration of the layers of the cornea. Now, but it is a clearly single ulcer which is going to see in here. So please mention here the clinical features. Before this starting the clinical feature, just talk about the cause. So what is the cause? Of course, there is a bacterial infection. The bacterial infection is the cause of your bacterial your bacterial corneal ulcer. And what will be the clinical feature of it? So with the clinical feature, just talk about your type of ulcer. So there will be the single ulcer will be seen. There will be the single ulcer will be seen on the cornea. And please remember about it. This is having the single ulcer. With this, importantly, you have to understand it. This is having the clear cut margin. So it is having the clear cut margins. Okay, so it is having the clear cut margins. As you can see over there, it is having the clear cut margins. So what I can do here, I can draw over it. I can draw over it that this is the area which is involvement, which is having the involvement of this ulcer. So this is the area which is having the your your ulceration over it, right? Of course, in the clinical features, if I'm talking about more clinical feature, of course, there will be the redness will be going to see. You can see over there. Of course, you can see the redness near the. Of course, the redness will be not over the your cornea, guys. Please remember about it. The one thing which I'm going to clear up here, like you will be going to ask me here, that sir, I cannot see the redness over the cornea, guys. Please remember, your cornea is the avascular structure. It is not having any vascularity. So there will be the hyperemia. It will be not going to see. The hyperemia will be not going to seen over the cornea. So where will be going to see your hyperemia? Or your collection of the blood will be going to seen over where? Yes, your collection of the blood or your redness will be going to seen over the this redness will be going to seen over the your conjunctiva only, right? So you can see up there the nearby conjunctiva will be totally red, right? So it will be the redness will be going to seen. Of course, there will be the pain will be more. Yes, there will be the pain will be going to seen there. With the pain, of course, there is a watering will be seen from the eye. And of course, if this ulcer is involving in the pathway of, it is blocking the some lights which is passing from the through the cornea. So of course the photophobia also, it will be going to cause your photophobia also. All right, so it will be going to cause a photophobia and watering from the eye, right? It will be causing the watering from the eye and the photophobia also. All right, redness will be there and the pain will be there. If I'm talking about the pain, of course it is a severe pain. It is a severe type of pain will be going to see. Now, if I'm talking about it, there what will be going to do in that part of diagnosis? If I want to make the diagnosis over it, so what will I going to do in this condition? So as per it, it seems me clearly, all right? It seems me clearly. First of all, I have to diagnosis. I have to make the diagnosis clinically. The first thing, of course, I have to make the clinically diagnosis. Yes, I have to diagnose the clinically. But after the making the clinical diagnosis that I seen over there, that yes, this is a single ulcer having the clear margins. Of course, I have to do some lab reports, or we can say the lab diagnosis, or we can say the confirmatory diagnosis. So for this, what I will do, will use the corneal scraping. We're going to scrap up the cornea, and we're going to do with this corneal scrapping, we can do the gram staining. We're going to do the gram staining. With the gram staining, over that, with the gram staining, we can do the culture, right? We can do the culture of the organism also. And what type of culture we can do on the blood agar? We're going to do the culture over of the on the blood agar, because it is your guys bacterial infection, right? So in the bacterial infection, of course, for the knowing the bacteria is the gram positive bacteria or the gram negative bacteria is there. Of course, first of all, I will be going to do the gram staining, and after the gram staining, if I need the more confirmation of it, so of course for that, for the culture and sensitivity test, we can do up if the again and again we are the patient is getting the ulcer over it, so we can do the culture and the sensitivity test also. So for that we have to do the culturation over the blood agar, over the blood agar. Now this is about your diagnosis part, but what should be now in the treatment part? What should be the part in the, what is the treatment part over here? Of course we have to give the antibiotics, of course, in a form of eye drop. Yes, in the form of topical, you can say the topical, it is your eye drop. Yes, topical form. In the eye drop form I will be going to give the antibiotics, because guys, the cause of this ulcer is the your bacteria only, so of course I have to give the antibiotics, and of course we'll be going to give here the broad spectrum antibiotics in a tropical formation like your ceftazidime, right? And with this we have to give the atropine also. And of course, what is the use of the atropine? Will be going to decrease the pain. It will be going to decrease the pain. Now, but one thing which will be have to remember here in the part of treatment, which I'm going to here write it down, there is a contraindication of steroid eye drop, or there will be the clearly I'm telling about you, say no to the steroid. Okay, we don't give the steroid in this condition, guys, please remember about it. If the options are given to you in the exam, that what is the treatment part of your bacterial corneal ulcers, and of course the steroid is mentioned there, there is the antibiotics is mentioned there, so please remember there, please remember there is a contraindication is what? Steroid. We don't have to prescribe, or we don't have to give the steroid to this person. Is it clear to you? Right, so the steroid, no to steroid. Okay, we don't give the steroid in this case. Okay, very good. Let's move forward, let's move forward for the next type of your corneal ulcer. Moving forward for the next type of the corneal ulcer, which is your fungal corneal ulcer. Now, in the fungal corneal ulcer, what will be going to see in this case? Just you can see up the ones in the image, guys. What is this? There is a not the single ulcer. Can you see up here? It is not the single ulcer. It is having more ulcers will be going to over there. And of course, as I'm trying to draw about it, but it is having the feathery margins. Yes, you can see it is having the very light feathery margins, not the sharp or the clear cut margins that I can draw up on over there. Of course, it is having the fluid in the anterior chamber, which is known as your hypopyon. Yes, this is known as your hypopyon, right? So this hypopyon, it will be going to available there. Of course, hypopyon can be seen in the your, it can be seen in your bacterial ulcer also, bacterial corneal ulcer also. But please remember, in the bacterial corneal ulcer, if the hypopyon will be going to available there, this hypopyon is having the different characteristics. And of course, in this condition, it is having the different statistics. But please remember, if the hypopyon is there, for the making the lab diagnosis, it will be quite easy. Just we'll take up the sample of this hypopyon and we'll do the gram staining and the blood culture of it. If we do this, if we do the culturation of that, if we do the gram staining of that, it will be quite easy to diagnose is of the it. Is that clear to you guys? So if we don't need to do the scrapping of it, right? Yes, we don't need to scrapping of the it. Just will be going to get the, we're going to get the clear cut, we're going to get the clear cut conclusion of it, that if the hypopyon is available there, we'll get this hypopyon and do make the laboratory diagnosis. We're going to make up from this laboratory diagnosis. Is it clear to you? Right, now moving forward for the next, now moving forward for the next thing that we have to see in this condition, that this is having the, first of all, talking about the causative organism. So this is caused by the your fungus. Yes, fungus. And there will be the, of course, as we already talked about it, the important thing is here, which is the, in the question I mentioned there with the highlighter, there is a, of course, the history of trauma of eye by vegetative material Of course. So there will be the always and always, please remember about it. Now you are talking about it, sir. What is the mean of this your vegetative material? Please remember, in the vegetative material we have, like, there is a stem or maybe the leaves. This is going to injury, right? Which is the plantations, right? If I'm talking about the vegetables, like vegetative matter is the what. So we have the some plantation like a stem of the or some tree, or maybe some the leaves of the tree. This is having the trauma to the eye. So such kind of the traumatic history, such kind of the traumatic history will be going to get the fungal ulcer over it. Now if we're talking about the ulcer type, so please remember, write it down, it is having the multiple ulcer. Of course, you can see over on the screen is not the clear-cut single ulcer, but just compare to it with the bacterial one. The bacterial one was the clear-cut single ulcer, and this is the multiple ulcers, and it is having what? It's having phazy and not clear margins. Of course, it is not having the clear, it is having the phazy and the hazy. We can say the hazy and phazy, hazy, clear, hazy margins, right? So it is having the hazy and the not the clear margins. So I can draw up there where is the your bacterial ulceration is there. Now, if we're talking about the pain, of course, pain will be here also the severe type of it. What will be the next? Of course, there is a watering. Of course, redness will be going to seen there, watering, redness, pain will be there, right? You can see the redness over the conjunctiva, guys. Of course, there is a no blood avascularity is on the cornea, so no redness will be on seen on the cornea. Yes, no redness will be going to seen on the cornea. We will be going to see this redness. Yes, of course, this redness will be going to seen over the conjunctiva. This is seen on the conjunctiva. All right. Now, talking about that more, that will be on scene. That what is having more, the redness will be there, and the redness, yes, of course, redness will be there, and the photophobia also. Guys, please remember why the photophobia again. If this ulcer, if this ulcer is disturbing the light which is passing over here, this if it is disturbing the light which is going to passing over here, guys, of course, it will be causing the visual disturbance also, and the causing the photophobia also. So write it down, some visual disturbance also. Visual disturbance. If ulcer disturbs the light rays. Yes, if this light rays which is passing through over the cornea, if this will be getting disturbance over there, there will be seen what? Of course, there will be going to seen the, yes, there will be going to seen over the, there will be going to seen over the visual disturbance will be of course seen it. Now, moving forward for the now in the diagnostic part. Of course, it's the same in the diagnostic part. Of course, it will be your clinically. Of course, we're going to do the clinically diagnosis, but for the lab diagnosis, if I'm talking about the lab diagnosis, what I will be going to do, I will going to do the corneal scraping. I will take the corneal scraping or hypopyon. If the hypopyon is there, corneal scraping or the hypopyon. With this, what we're going to do for the bacteria, what we are doing the bacteria, we'll do the KOH mount, KOH mounting. We're going to do the KOH mounting, and of course we can do there will be the your culture also. Yes, we can do the KOH mounting should be done there, or we can do the culture also. The culture should be on the nutrient agar. Yes, the culturation should be done on the nutrient agars, and we're going to get the lab confirmation diagnosis from the laboratories about the which type of fungus is growing over there. Now, but if I'm talking about the your what should be the your treatment part over here? What will be the treatment? Of course, it will be your antifungal. Yes, in a form of eye drop. We're going to give the antifungal eye drop should be given here. And with the antifungal eye drop, of course, the patient is having the pain. So we have to give the atropine in the eye drop form. But please remember over it again, which I mentioned in your bacterial corneal ulcer also, and I'm going to mention over here there is a contraindication in the treatment part. Please remember what? Your steroid eye drop. Yes, we don't have to give the steroid in this condition also. Guys, please remember, we're not going to prescribe the steroid to this patient also, right? So steroid is contraindicated in your bacterial corneal ulcer also, and of course in the bacterial corneal ulcer, and also in your fungal corneal ulcer, right? So please remember your, yes, very good, it will be your ban. You can say the contraindicated, it will not going to use, guys, will not going to use your, yes, will not going to use the steroid in this condition, in the bacterial corneal ulcer over your fungal corneal ulcer. Is it clear, guys? Very good. Very good, very good. Now, let's move forward. Yes, 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 doctor. Will, yes, will not give this steroid, will not give this steroid in such, yes, in this condition, will not going to give the, yeah, very good. Now, moving forward for the next one, which is your herpes simplex corneal ulcer, or which is known as HSV, also known as viral keratitis. Yes, which is known as your viral keratitis. And in this condition, what will be going to seen to you? There is the ulcer which is not clearly visible on the your or this will be not clearly visible on the cornea. For this, for visibility of this, we have to inject it over there. You can see this fluorescent dye. We have to inject it there. We have to give the eye drop of the fluorescent dye, and after the giving this fluorescent dye, we're going to use the cobalt blue filter over the slit lamp. I will going to put the cobalt blue filter. I will going to put the cobalt blue filter over the slit lamp, and after it, I will going to see there is a some ulcer. Can you see this take up of this fluorescent dye? Can you see there? And what is this ulcers, guys? Please remember, this is your dendritic ulcer. Yes, this is what? This is your dendritic ulcers. Now, let's talk about it. What will be your cause? So the cause is by the given in the name. What is the herpes simplex virus is the cause of your viral keratitis. Your herpes simplex virus is the your cause of your viral keratitis. Right? Yes. Yes, doctor. Now, now this will be the cause. Your HS will be your cause of your viral keratitis. And please remember about it. What will be your clinical features of it? So of course, if I'm talking about your ulcer, so first in the starting stages, it will be going to see in your dendritic ulcer, and later stages. In the later stages, it will be seen in your geographical ulcer. Yes, it will be going to see in your geographical ulcer. Yes, so now Now, in the geographical ulcer, or we can say the morphological ulcers. Yes, geographical ulcer also. Yes, 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 doctor. You can write up there. What kind of geographical ulcer? Just this will be the depression of it, right? Yes, geographical ulcer. Morphological and geographical, you can write it down both of it, right? Geographical ulcer. We're going to mention here geographical ulcer only, right? Now, let's talk about it. The more clinical feature, of course, it will be the painless ulcer. Yes, no pain will be there. Am I highlighting it with the your highlighter? So you'll be going to remember here. Yes, the patient is having no pain in this condition, and that's why it is not visiting to the patient in the early stages, right? And of course, there will be the watering. Yes, it can be the watering can be of course it will be there, and redness will be can be seen. Either else, there will be the no visual disturbance and then nothing will be the symptoms in this patient, and that's why this patient is not coming to it. In the it will be not going to come the to the your OPD. Right now, what in this condition will be going to happen later? Now, in this condition, that the patient will be not having such things, so of course it will be going to come up to you, and of course it will be your making the diagnosis of this patient. For the making the diagnosis of the patient is the only the clinically. We're going to make the clinically diagnosis of this patient. Yes, clinically diagnosis of the your this patient. So clinically diagnosis will make the clinical diagnosis of this patient. We're not going to do any investigations of moreover on this lab diagnosis. Other things will be on this particular patients. But we're going to do the injectable of the fluorescent dye. We're going to do in see it on the cobalt blue filter. We're going to see these things, right? For the making the clinical diagnosis. But now, then what should be your treatment part? What should be your treatment part? What is happening, guys? If your patient is coming into the early stages, we can give the antiviral eye drop. You can give up their antiviral eye drop, but the patient is not over the coming to you in the early stages. Why not coming into your early stages? Because you don't have any pain, guys. So the patient will not going to come up there. So in all the conditions, or we can write it down, the drug of choice of this is the your steroid. And in this condition, we can give the acyclovir 3% eye drop. We can give this the acyclovir 3% eye drop we can give. Yes, acyclovir, then acyclovir also can be given. Yes, 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 you can give over there, right? The acyclovir we are more overusing, right? The acyclovir will be the more overused there. Perfect, 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 right? But please remember, yes, your drug of choice will be remain the steroid here. So now in your mind you can understand this thing, that's that in the cases of your bacterial ulcer or in the corneal ulcer. Yes, in the bacterial conjunctival ulcer or the fungal ulcer, the steroid is the contraindicated. But in the viral ulcer, right, or in the viral keratitis, this is the drug of choice. This is the drug of choice in this case. Is it clear to you guys? Is it clear to you? Very good. Very good. Let's talk about it. Let's talk about it later. The next one, which we are having the acanthamoebal keratitis. Now, if we're talking about the cause, so of course, what will be the cause? Of course, the acanth, by the name only you're understanding, acanth amoeba. The amoeba will be going to cause up here. Now, if I'm talking about the next, which is about your clinical features. And in the clinical features, just if I'm looking over this image, what I can see over there, guys, what I can see over there, I can see it is looking like a ring shaped ulcer. Can you see? It is making a ring over there. Yes, over the eye. So this is known as your ring ulcer. Yes, it is known as your ring ulcer. Now, in the acanthamoeba, right? Yes, acanthamoeba will be because in this case, the patient is having the ring ulcer. So the shape of ulcer will be your seen to you ring ulcer will be going to seen. After over it, please remember with this ring ulcer, the patient should having the history of misuse of corneal, your corneal lenses. Yes, so the patient who are having the refractive error, they are using the they are using the lenses over the cornea, which is known as your corneal lenses. Yes, corneal lenses, or you can say the contact lenses. We are saying in the corneal contact lenses. So there is a history of misuses. Now you are guys asking that what kind of the misuses can be mentioned in a clinical case, sir. So please remember about it. There can be mentioned, of course, they can be mentioned you the patient is having the for the more longer time of this your lenses, corneal lenses. He is not changing the lenses over the period of it, and not having the hygienation when it is removing and putting it and again using of it. And maybe guys, sometime what is happening, this has happened due to the making of this physiological solution. I hope you remember about it. When you are guys are using the contact lens or the corneal lenses, you have to put this lens into the physiological solution. But some of the patient is doing what, to avoiding this, they are making the same physiological solution by themselves, and they are using the water will be used there. And of course you already know this water is having the our amoeba. If this amoeba will reach over the your corneal lenses, and you put it that same lenses with the patient when there is amoeba is available, so of course it will be directly your amoeba is going to reach over the cornea. And guys, that's why only this patient particularly having the history of misuses of your corneal corneal lenses. Of course, with this here, if I'm talking about this patient, please remember there is a severe pain. Of course, there will be the more pain, guys, rather than the corneal ulcer, and rather than the yes, rather than the corneal ulcer, and rather than the your fungal ulcer. The patient, because of the neuralgia, because there is the involvement of the nerves over the cornea, and this is going to cause your neuralgia, right? This will be going to cause up your neuralgia. This is the causing your neuralgia. Now with this, the patient can be seen the redness, very less redness can be available there. You can see up there. And of course this is causing the photophobia, and visual disturbance will be also, guys. Of course, the visual disturbance will be going to seen over there. Now, the redness will be there. The your watering will be there, can be seen. Redness will be there. Photophobia will be there, and your visual disturbance will be going to seen over there. Now, for making this diagnosis, of course, we are making the clinically diagnosis, but for the lab diagnosis, we are doing the corneal scraping again. And this corneal scraping should be in the your cauliflower stain for the specifically for the your acanthamoeba, and you can do the culture over it, culture on the non-nutrient agar with E. coli. Yes, so there will be going to see in the non-nutrient, it will be going to grow over the doing the culturation of the amoeba on the non-nutrient agar or with the E. coli. Please remember with the E. coli. Okay, with the E. coli. Yes, but now what should be in the part of your treatment part? In the treatment part, please remember, of course, we're going to give the atropine for the making of it. But what should be here? We'll giving the drug of choice. Yes, PHMB, polyhexamethylene brigamide. Yes, PHMB, polyhexamethylene brigamide is the drug of choice of the cases of your acanthamoebal keratitis. Of course, we're not going to use the here steroid because steroid will be not going to do anything, will be here. So we'll not use the steroid, and even the steroid is not even the contraindicated in this condition. But the drug of choice is your PHMA. Of course, we're going to give here the atropine eye drop because this will be going to decrease the pain in this patient, right? So we're going to give this patient the atropine should be given to this patient. With that, we're going to give the PHMB, right, which is your polyhexamethylene brighamide is the drug of choice for this your acanthamoebal keratitis. For the acanthamoebal keratitis. Very good, guys. Right? Yes, yes, doctor, we're going to use this. Perfect. Let's move forward. Let's move forward for the next one. The next is also the now this is also your degenerative type of the your your condition of your cornea. But please remember what will be going to seen here. This is the your case of keratoconus. This is the case of your, this is also the degenerative condition, yes, but this is not the degenerative condition of the your conjunctiva. This is the degenerative condition of your cornea. We are talking about the now the cornea. So this is the in the keratoconus, what will be happen, please remember, it will be increasing the curvature of the cornea, and due to the increasing of curvature it will be decrease the thickness. Yes. Now what is happening in this condition? As there is a curvature will be going to increase over it. As there will be the curvature of your cornea will be going to increase over it. What will be going to seen? There will be the decreasing in the thickness. What will be going to seen? There will be seen the decreasing in the thickness will be going to seen. Now, if there is a curvature will be going to increase. Guys, please remember, if the curvature will be going to increase, so of course, it will be going to cause your curvatural myopia. What it will be going to cause? Yes, yes, curvatural myopia. We already talked about it. If there will be the increasing of the curvature, it will be going to increase the total eye power, right? And it will be cause the curvatural myopia. And with this curvatural myopia, guys, please remember about it. There will be the what will be happen? There will be the vertical and the horizontal axis. There is the vertical and the horizontal axis of your eye will be disturbed. And due to this condition, there will be the astigmatism will be going to seen. So you can see up there will be the impaired vision due to the myopia and with the irregular astigmatism. So this particular patient is having the refractive error due to the keratoconus is the myopia because of increasing the curvature. It is having the curvatural myopia, and of course the patient is having the different of the visual axis. It is having the vertical and the horizontal, both are different axis. So that's why this patient is having what? This patient is having the different vertical and horizontal, both are the patient is having the different axis. So that's why the patient is having what? That's why the patient is having the astigmatism also. And which type of astigmatism? Irregular astigmatism. So what is the cause of it? What is the cause of it? Please remember, it is having the non-inflammatory, your actatic condition. It is having the non-inflammatory actatic condition of the cornea, which is giving the corneal shape with the resulting in the irregular myopic astigmatism. And that's why there will be going to seen to you. You can see up there. It will be going to increasing of the your corneal curvature. All right. Now it is usually bilateral in the patient. Near the 85% of the patient is having the bilateral, and of course, please remember it is having more commonly seen in the girls after the puberty. So it will be more commonly seen, guys. Yes, it will be more commonly seen with the girls and after the puberty. After the puberty. Now, there will be going to see some important clinical features. Of course, we have to make the diagnosis here also. The clinical diagnosis will be going to make, and some tests like pachymetry, pachymetry test will going to perform will be there for the thickness and the curvatures, of course, right? But please remember about it. Please remember about it. We have to make some clinical diagnosis. For the making the clinical features, for the first sign, which is your Munson sign. So you can see This is the image number 1 you can see up here. And what is this? A Munson sign. Please listen up this. As there is a corneal curvature is increased. What we're going to see here, guys, please remember, as the corneal curvature is going to increase over there, when we say to the patient, to look downwards. Yes, when the patient, we have to say to the patient in the Munson sign, what is happening? Please remember this part. When we are saying to the patient to look downwards, and as this patient is looking downwards, what is happening? On the looking of the patients downward, there will be the depression over the, there will be the seen the depression over the, you can see here, there's a depression over the, there's a depression over the lower lid. Can you see this? Can you see this? Cornea is going to depress the your lower eyelid. But is it happening in the normal patient? If I'm looking downward, is my cornea will be going to making depression or touching on the your your making pressure on the your lower lid? Not possible. Not possible, guys. But in this case of this patient, there will be the making the depression over the it. Right? It will be going to make the impression over the it. Now, this is known as your Munson sign. This is known as your Munson sign. Of course, with this next one, if I'm talking about it, there is a known as the second one, which is known as your Vogart sign. And you can see over it what is happening in the Vogart sign. In this case, in the Vogart stria, what is happening? There is a stria marxis. There is a stria marks in descent membrane. In the descent membrane of cornea. Why it is happening, guys? Please remember, as there is a stretching of your cornea, as there is a stretching of the cornea is seen there, due to the stretching of the cornea, there is a stria marks will be going to seen. And please remember, as it's starting from the V word, so of course there is a vertical stria. Yes, so there will be the vertical stria marks will be going to seen in this conditions. And this stria marks, I hope you can see in this condition, there's a vertically stria marks will be going to seen in the your descent membrane. The last one, which is the third one, which is your Flesher's ring. And what is this Flesher ring? Guys, please remember what is happening. This is having the base of the cone, right? So this is the base of the cone. And you can see at the base of the cone here, the iron is getting deposited. Iron is deposited on the base of cone. Yes, on the base of cone, there will be the, on the base of the cone, there will be the iron deposited. And this, you can see, this will be giving a flashing, this is giving the redness. A strip will be going to seen over there. I'm making highlight over it. This one in the box. I hope is it clearly visible to you. And this thing is known as your Fleshner's ring. This is known as your Fleshner's ring, right? So this is what? Yes, this is your Fleshner's ring. Now, let's move talk about the your here. What will be the here diagnosis of this patient? We're going to make the clinically diagnosis, and of course for the lab diagnosis we can do the pachymetry, or we can do the topographical topography or the tomography. We can do up there, right? Top pachymetry, we can do the topography, tomography. This task we can do up there. But what should be the now in the treatment part? Please remember about it. What should we do in the condition of this keratoconus in the part of treatment? Please remember, this is a two type of the treatment will be there. First one, which is your temporary. For the temporary, we're going to give the patient RGP lens. What is this RGP lens? This is the corneal lens, or you are saying the contact lens. Yes, what is this? This is your cornea based lens. You have to put the cornea lens. This is not the normal lens, guys. This is a special type of rigid gas permeable. Guys, please remember it is what? Yes, this is your rigid gas permeable lenses. And yes, this is will be going to cover, this will be going to getting the treatment of the patient of the keratoconus. Now your mind is saying, sir, the patient is having only the issue with the increasing of the curvature. The patient is having myopic irregular astigmatism. Can we treat up this patient? Can we treat up this patient with the can we treat up this patient with the your specs? Is it possible? No, guys. Please remember the glasses cannot correct this keratoconus patient. We're not going to prescribe the in the lower or in the starting stage of the patient. We can prescribe the glasses for this keratoconus patient, but in the later part we have to go. We have to, because the patient is having the in the clinical feature. The patient is having the difficulty vision with the glasses also. So that's why we're going to give the we're going to give the patient to the we're going to give the RGP lens. But what is the mean of your permanent treatment? And in the permanent treatment, of course, it should be your surgery. And what is the first one, which is your keratoplasty? What kind of keratoplasty? It is your penetrating keratoplasty. Yes, it should be your penetrating keratoplasty, right? So we're going to do the penetrating keratoplasty in this condition. Also, we can do the C3X and CRX surgery. Yes, this is the collagen based surgery. This is the your C3R, C3R, CXR, CXR. Yes, C3R, CXR surgery, which is the your what? Yes, this is the your corneal collagen based surgery, right? So yes, doctor. C3R, C3R, CXR. Yes, C3R, CXR surgery, which is the your collagen based surgery, we're going to do in this condition. And yes, we're going to correct the corneal collagen based. This is the based on the corneal collagen. Yes, we're going to do the surgery on the base of the corneal collagen, on the corneal collagen. Yes, perfect. Yes, doctor. Yes, agree with you. Right? Now, let's move forward. The keratoconus finished there, right? There is a keratoconus is finished there. Now, moving forward for the next disease. For the moving forward, just I'm informing you, if you guys have any queries related to this sessions, you guys can contact me personally on my Instagram, which is your dr.Vaibhav Ahuja, or you can directly ping me on my Telegram. My Telegram username is your Dr. Vaibhav Ahuja. And for the more such sessions, if you needed have any queries, you guys can contact us on the Meduhub team, right? So you can contact the your our Meduhub team also. They will be going to help you in this condition, right? So if have any queries related to the such sessions, have any query related to the ophthalmology, you guys can directly contact me over there and have such queries related to the sessions and more queries if you need it. So you can contact the Meduhub also, right? Very good. Now, moving forward for the next MCQ, and in the next MCQ, we are talking about it. We are talking about the that about the our your question which is in front of you, and this is your question number 11, which is asking you about the some refractive error. So there is a patient which is having the refractive error present in a 19-year-old female, and it is exhibiting the streak of light moving opposite to the retinoscope motion during the retinoscopic test. So the question is asking about the your from the retinoscopic test, and this retinoscopic is test is done from the 1 meter under the tropicamide, yes, which is your dilator, yes. Now we dilated the eye from the tropicamide and had from the 1 meter we are doing the retinoscopic test. The female patient is having what? the patient is having the your opposite. Yes, opposite to it. It means it will have the uh, against the direction. Yes, against movement. We have the two movements, same movement and against movement. So we have the against movement in this condition. Now, guys, please let me know in the chat box. Please let me know in the chat box what will be the your answer in this case. The options are given there. The first option are given here. The patient is having the emmetrotropic. What is the mean of emmetrotropic, guys? The patient is having the no visual dis or no refractive error. It means the patient is having the normal. Is it the patient normal? Of course, if the patient is the normal, there will be the neutralization of the your reflexes. So this is not the possible, guys. This is not the possible. Now we are moving forward for the next options which are given there. They're given the option the hypermetropic. Option B is your hypermetropic, and option C is your myopia, but myopia which will be your greater than, yes, your myopia which will be the greater than the one diopter, and myopia of one diopter. So the options are given more differently, right? But what I know about it, if the myopia is there, so in the myopia, and if the myopia is less than one diopter, if myopia is less than one diopter, we are getting what? We are getting the same movement. Yes, in the both. And if the patient is having myopia greater than the one diopter, we are having the more than the one diopter. The patient is getting what? The patient is getting the against movement. Yes. So by the seeing of this retinoscopic test, I hope you had done studied very well the retinoscopic test. If not, of course, we can talk about this test also. Now, so this is the case. So now is it clear to you? The patient is having the against movement, as we talked about, is it's going opposite to the retinoscopic motion. So the answer should be here your myopia, which is greater than the diopter, one diopter, right? So the patient is having what? The patient is having the myopia, which is having the more than the one diopter, right? More than the one diopter. Now, moving forward for it, now we have to talk about, yes, this is the answer. Moving about it now, a little bit about the optics and the refractions. Let's talk about it, about the optics and the refraction. Moving forward for the optics and refraction, starting with the more important MCQs, which is high yield and can having the more chances to come in your FMG exam. The refractive power of the eyes, and this is the total power of eye. It will be your plus 60 diopter. What is the cornea's power? It is your 44 diopter, plus 44 diopter, and of course what is the lens power? Plus 16 diopter. If I'm writing about the variation, it can be 58 to 60 diopter variation. If I'm talking about it, what should be the cornea? It can be 42 to 46 diopters. We are taking up the average of it. Yes, actual values, we are taking up the average of this ratio. And the last one which we are having, the lens, of course the lens is having the power of 12 to 18 diopter. Of course the child is having the different power of the lenses, and the adult is having the different, but we are talking about that. If the actually they are asking you what is the total eye power, what is the total power of your cornea, and what is the power of your lens, so you have to go with this values, right? Of course they are asking you nowadays in the NEET PG exam also, they are asking you about the refractive indexes of media of the eyes. Like they have the cornea, they have the aqueous humor, they have the crystalline lens, and the vitreous humor. This is only the we have, right? I hope you remember about the clave, right? Which is your what is this? Your refractive media. This is your refractive media. So please remember, it is having the little bit of same values, so it will be getting more confused. But please remember, the cornea is having the 1.37 and the crystalline lens is having the 1.39. So just remember, the 7 is coming before the 9. Yes, first 7 and then 9. So please remember, the cornea is the first and lens is the behind it. So 1.37, 1.39. And of course, our aqueous and vitreous is having the same 1.33, 1.33. Right? So just remember with this mnemonic or this style, you have to remember the cornea is the first, right? And then later we have what? We have the later we have the lens. So the first what we have, the first we have the cornea. So the cornea is the 1.37, and behind the cornea we have the crystalline lens. It is having the 1.39. And yes, please remember, as we have the aqueous which is filled in the your anterior segment and the vitreous which is filled in your posterior segment, they both are having 1.33, 1.33 of the your refractive indexes. Okay, so just remember these values. They can ask you some MCQ from this such values, right? They can ask you such values as the MCQ. Is it clear, guys? Is it clear? Very good. Let's talk about it. Let's talk about it. Moving forward for it. Now, at the birth, when we are having the child is had the birth, so it is having not the normal eyes. Yes, it is having a refractive error, which is a physiological hypermetropia by +2 or +3. So the child at the birth is having the hypermetropia. The child at the birth is the hypermetropic. And what is the power of that particular child's eye? Yes, it is the +2 or +3. It can be your +2 or +3. Now, moving forward for the refractive errors, and starting with the first one refractive error, which is your hypermetropia. By the name, you are understanding hypermetropia. And with the hypermetropia, the name, there's a written clearly, there's a clearly written long-sightedness, guys. Please remember, this is the very confusing name, which is the long-sightedness. And yes, here the examiner, here the examiner which mentioned here this name is because of only and only. Please remember, here the examiner mentioned this clearly to confuse you. But now I'm going to clear up you this thing, so you will be not getting confused with this such words. Now, talking about the hypermetropia, what is happening in this condition of the hypermetropia? That rays which are coming from the away parallelly, they after the making the refraction, they're going to meet behind the retina. They are making the focus point behind the retina. The actual focus point should be needed here on the retina. So what is the making? Yes, in the hypermetropia, the rays after refraction, after refraction makes makes focus point, focus point behind the retina. Okay, and now listen the part of it why it is known as the long-sightedness. Just remember about it that the normal is here, the normal focus point is here, and this focus point is behind, or we can say this focus point is more longer than the normal one. So this is the longer, yes, this is the longer than the normal, yes or no? So this is the longer than the normal, the focus point is making more longer than the normal. That's why this is known as the long sightedness. So the focus point is longer than normal one. Yes, that's why it is longer than the normal one. That's why, guys, please remember, this is known as, yes, that's why this is known as your long sightedness. That's why this is known as your long sightedness. Is it clear to you guys? This is known as your long sightedness. Now, so this is making the focus point behind the retina. Now, if I'm talking about it, what is happening in this condition? So please remember, there is a total eye power. Eye power is decreased. Yes. So there is a total eye power. If I'm talking about the eye power, we talked about it plus 58 adapter to plus 60 adapter is there. So this will be going to decrease from the normal. Yes. So it is not having the normal. The patient, of course, it is not having the normal eye power. It is having the decreased the eye power. Of course, it is having what? It is having the decreased eye power. And with this decreased eye power, if I'm talking about it, with this decreased eye power, if I'm talking about it, what is important? What is important? So that's why the patient is having what? Increasing of the longation of this your focus point, and which is behind. And what is the patient is having? The patient is having difficulty in near vision. Please remember, in the hypermetropia, the patient is having the difficulty in near vision. And what about the your far vision? Please remember, normal in far vision. Yes, there is a no defect in the far vision. The patient can see the clearly far vision, but the patient is having the difficulty. The patient is having the difficulty in seeing in the near vision. The patient is having the difficulty in the scene in the near vision. Now, sir, what to do in the part of the treatment part of this patient? Of course, we have to do. Of course, we have to do the patient treatment. Yes, of course, but please remember here the patient is having the what? There's the patient is having what? Yes, patient is having the near vision affected. So in the hypermetropia, please remember, in the hypermetropia, the patient is having the near vision affected. The patient is having the near vision affected. Now, we have to do the treatment of this patient. So for doing the treatment of this patient, we have to prescribe what we have to give the. So we can do the surgery, or we can give the contact lens, or we can give the patient to the treating of the with the eye lenses. Yes, so we can give the contact lens, we can give the eyeglasses. For the using of it, we're going to use the convex lenses, right? What we'll be going to use in this condition in the hypermetropia, please write it down. We're going to give this patient in the treatment part, we're going to give the convex, yes, we're going to give the convex lenses to this patient, which is your convex lenses is what? Your, write it down, your plus lenses. Yes, we're going to give the plus lenses to this patient. And please remember, in the hypermetropia, we're going to give in the spherical. Yes, we're going to give the in a spherical form. We're going to give the in the spherical form, not in the cylindrical. Of course, we're going to give the in the spherical manner. Yes, we're going to give the spherical manner. Very good. So that we have to give the convex lenses. Yes, we're going to give the convex lenses. And what is done by this convex lenses? Please remember, this convex lens will going to band this lights more over it, and will be going to focus on the retina. And if this will be going to make the focus on the retina, guys, the problem will be going to resolve. The patient is not having any symptom in the defect in the vision on the near vision also, right? So this is depending on the your glasses. Yes, of course, we're going to prescribe the glasses on the after the moving of the after making up of the diagnosis of this patient. Yes, after making up of this diagnosis of the patient, yes, this will be going to do in the diagnosis of this patient and the treatment of the patient of the hypermetropia. Is it clear to you guys? So this is about your hypermetropia. Now we are having the types of hypermetropia, guys. I hope you understand. In the hypermetropia, near vision will be going to affect it. Let's see about the types of the hypermetropia we are having. So what kind of the type hypermetropia we are having? First one, we are having the axial hypermetropia. Now, please remember this part. Please remember this part. What is the mean by this axial hypermetropia? In the case of axial hypermetropia, you can understand the first thing, which is your axial length. What is the axial length normally? 24 mm. Yes, we have the 24 mm is your axial length, which is your normal axial length in this patient. Now, listen this part carefully. If I'm drawing here one one diagram here just for the clearing you. This is the cornea, and this will be the your eye, right? So this light rays which are coming from here, it will be going to band up and making focus point on the retina. Yes, this is the normal eye. I'm making up here the normal eye. This is the focus point the patient is having on the normal eye. Please remember about it. This is the normal eye. But if your axial hypermetropia, what is happening? Your axial length is of eye. Your axial length of eye is decreased. If your axial length of the eye is decreased, so now check it out. I'm making a black color of the dot line. If axial length is decreased less than the 24 mm, so what will be happen? The power of your curvature of your cornea will be going to make the focus point here only, and the retina will be, and the length will be decreased, so it will be remain here only. The retina focus point will be should remain here only, and it will be away from, or we can say the behind the, it will be the behind the retina. So this will be your axial hypermetropia. I hope you understand about it. If the axial length, please remember, if your yes, your, if your eye axial length is decreased, this will be going to cause your axial hypermetropia. This will be going to cause your axial hypermetropia. So please remember, axial length of the eye is decreased than the normal one. That will be going to cause the axial hypermetropia. Now, with the second one, we are having the first one, this is your axial. The second one, we are having the curvatural. The next is the, we are having the curvatural hypermetropia. In the curvatural hypermetropia, we are having what? The curvature. So if the curvature is decreased or flattening of cornea is seen. Yes, if the flattening of the cornea is seen, or there is a decreasing in the curvature of your cornea will be seen. So the curvature, if the normally we have this curvature of the cornea, right, and if will be going to decrease like this flattening, right? If the cornea is getting flattened, so of course this will be going to decrease in the your total eye power, and of course this is known as your curvatural hypermetropia. So this will be going to known as your curvatural hypermetropia. So there is a two type of the hypermetropia which we talked about here, the axial hypermetropia and the curvatural hypermetropia. Please remember, in the both condition it will be going to decrease. If axial length is going to decrease, it will be going to cause your axial hypermetropia. If your curvature, please remember, if your curvature of your cornea is going to decrease, and the, we can say the flattening of, we can say the flat, yes, we can say the flattening of the your, yes, we can say the flattening of the cornea will be going to seen, that will be going to cause your curvatural hypermetropia. That will be going to cause your curvatural hypermetropia. Let's move forward for the next one. This is about the hypermetropia. Now we are moving forward for the myopia, which is the second type of your, which is your second type of your refractive error. And please remember, in the myopia, this is known as the short sightedness. Guys, we talked about the long sightedness. I hope you remember why this was there was the focus point was longer than the normal one. And what is happening in this condition, you can see here this rays which is going parallel to your light rays, after the making the banding, or after the making the refraction, it is making the focus point It is making the focus point here before the retina only. The normal focus point should be on the retina, but this is making the focus point. This is making the focus point just before to the retina, right? So what is this here? The focus point, focus point is before the retina. Yes, and whatever we talked about here, you can see this is the longer than the normal one, or we write it down there. There's the focus point which is the behind the retina. Yes, but what we are talking about here in the myopia, this is before the retina. So you can see if the normally focus point should be going to over here, it is shorter than this. Yes or no? It is shorter than the normal. Am I right? It is shorter than the normal or not? Yes, it is shorter than the normal. So please remember that's why it is known as your short sightedness. So write it down here. The focus point, the focus point of myopia is the focus point of the myopia is shorter than normal one. That's why this is known as your short sightedness. Please remember that's why this is known as your short sightedness. If I'm talking about the total eye power, please remember the total eye power. The total eye power is increased here. The total eye power is here increased here, right? So the total eye power will be increased. Yes, as we talked about it, what is our total eye power? Our eye power is what we are having. The our eye power is your your 58 to 58 to yes, 58 to 60. Very good. But what will be happen here? What will be happen here? Yes, this will be your, yes, doctor, this will be going to, this will be going to increase. So it will be going to increase. Yes, it can be 50 more than the 58 or 60, right? And it will be more over it, right? It will be the more over it. So this will be going to increase up there, right? Yes, there will be the increase up of it, right? Now if I'm talking about it, what will be the, there will be the features of it. Please remember there is a difficulty in, difficulty in far vision. There is a difficulty in the far vision. There is a difficulty in the far vision. What about the near vision? Of course, there is a normal near vision. There is a normal near vision, guys. In the patient of your myopia, it has clearly, he can read up the all the things from the nearby. But what about the far vision? The far vision will be going to affected in this condition. So what should be now the treatment part of it? Of course, we can give up, we can do the surgery. We'll talk about in the later part. We can give in the refractive error of the treatments, we can give the eyeglasses, we can give the contact lenses, or we can do the surgeries over it, right? So in this condition, we can give the eyeglasses, we can give the contact lenses, we can give the surgery, we can prescribe the surgeries also. But if I'm talking about the glasses, so which glasses will we give? We'll give, going to give the concave, concave type of the lenses, which is your minus lenses, which is your minus lenses in the spherical form, in the spherical form. So we're going to prescribe here in this patient for the concave minus spherical lenses. Concave minus spherical lenses should be prescribed in this patient, right? And the patient will be going to relieve by this. The patient will be going to relieve by this. Okay, right? Okay, yes, we're going to give the concave type of the glasses or the minus lenses. Yes, minus lenses. Why we are giving the minus lenses? Because the patient is having the more eye power. The patient is having the 68, 69 or maybe 65 diopter of the eye power. So we are trying to decrease it to the normal. So we're going to prescribe the minus lenses. As we give the minus lenses, the patient will be getting this. Is it clear? Very good. Now moving forward. Now we are moving forward for the next one. There is a type of myopia is also given. There is a three type of myopia is given. The first one, the same, we talked about it, axial. The second one is the curvatural, and the third one, which is your pathological. Right? So we have the axial, we have the curvatural, we have the pathological. Starting with the axial myopia, what is the seen in the axial myopia, guys? Please remember, there is an increasing in axial length, right? So what can be happen? If the normal axial length is what? Normal axial length is 24 mm. If it is more than that, then what will be happen? Just I'm drawing a simple diagram again, that this is the your eye and it is having the this rays will be going to meet up in the normally on the focus point of the retina. If your axial length of eye is increased, so I'm drawing with this black color. If your eye length is increased, so of course it will remain just before the retina. Yes, it will be remain where? It will remain the before the retina, and this will be going to cause your myopia, right? So this type of myopia will be going to known as your axial myopia. Yes, so this type of is myopia is known as your axial myopia. So please remember which type of axial. Yes, in the axial myopia, there will be the increasing in the axial length. The same thing in the curvatural myopia, we talked about it. There will be, of course, here also increasing in the corneal curvature. We talked about it in the curvature increasing. We talked about it, guys. We talked about in the keratoconus. Let me know in the keratoconus what we had. In the keratoconus, we are seeing the increasing in the curvature of the cornea. What we saw the increasing in the curvature of the what we saw. Yes, we saw the increasing in the curvature of the cornea. So when the curvature of the cornea, when your curvature of the cornea will be going to increase up there, so because of increasing this curvature, because increasing in this curvature, there will be the there will be the increasing in the refractive power, and of course due to this curvature will be going to increase. Yes, there will be the like normal curvature is like that, but if it is increasing more, you can see it is increased more, the curvature increase more, it will be going to cause your curvatural myopia. Yes, it will be cause your curvatural myopia. So axial myopia, curvatural myopia. The last one, which is a pathological degenerative myopia. In this condition, what we can see, there will be the degeneration of, there is a degenerative changes on the macular region, or maybe any tumor, tumor inside eye, which is your intraocular tumor. Yes, inside the eye, which is your intraocular tumor. Yes, this is the intraocular tumor. Yes, this will be going to seen in your intraocular tumor, right? Very good. Now, should we move forward? Yes. Let's talk about it. Let's talk about it. We have the special type of, we have the here, we have to talk about the especially about the, we have to talk about the specially type of your pathological. So this is the, there will be the pathology will be seen there, but what about the axial and the curvature? Of course, if the curvature will be going to increase, this is the curvatural. If there is a curvature will be, if your axial length will be going to increase, this is your axial myopia, right? So now is it clear to about you? Now we are moving forward for the third type of your optics and the refractive error, which is your astigmatism, which is your astigmatism. For talking about the astigmatism, I'm clearing you in a very clear manner. We have the five type of your astigmatism. For understanding it, it is quite easy. I don't know why the students are always asking me such questions, sir. Why this your why this our astigmatism is a very difficult, right? Please remember, your astigmatism is not such a difficult thing. It is quite easy. Just you have to understand it. Just you have to what? You have to understand it. For understanding it now, I'm telling you such important things. Just please remember about it. In the condition of the astigmatism, what is happening? We have the vertical and the horizontal axis, right? We have the vertical and horizontal axis in our eye, right, in the cornea. So you can see then the normally the patient we have the vertical is equal to the horizontal, right? Our vertical and horizontal both axis will be the same. Yes, guys, your vertical and horizontal axis will be remain same. But just a minute, guys. Now, what is happening in this condition? Now, what is happening in this condition? There is a vertical and horizontal. Our always and always our vertical and horizontal axes remain equal. But if there is the changes, if your vertical is more than the horizontal or your horizontal is more than the vertical, right? If this happened, what will they will do? What they will do? Now listen this part. If they are same, they are making the one focus point. And if they both are different, they will be going to make the two focus point. Did you understand? So if in this condition the patient is having the vertical or horizontal axis changed, right? So now the both axes are changed, not the equal. So they both will be going to make this both will be going to make the different focus point. So the two focus point will be going to seen. So this two focus point, if in any type of refractive error two focus point are seen, that is known as astigmatism. So you can see the corneal with the astigmatism. What I'm seeing the two focus point. The one which is here, f1, and the second one is here, which is f2. Yes, so I hope you understand now why the two focus points are is here, because always and always our eye is having the vertical and horizontal axis is equal. That's why we are having only the one focus point. As we talked about in the myopia, in the hypermetropia, there was a one focus point only was there. Of course, it was not on the retina. It was just before the retina in the myopia and behind the retina in the hypermetropia. But there was only the one focus point. But if in this condition I'm talking about in the astigmatism, we have the two focus point. Now, if you understand about it, just talk about it, that what is happening with this. If the two focus point is there, please remember the patient is having difficulty on the based of the which type of refractive error, but difficulty in vision. What difficulty in the vision? There is a blurring of vision is seen. Yes, there is a patient is having the blurring of the vision. It's not like that. Of course, there will be the myopia, the myopic astigmatism or hypermetropic astigmatism. Of course, it will be there. It will be there. But please remember, it is not like that there is a difficulty. What kind of difficulty? Of course, there is a blurring of the vision will be going to seen in this patient. Now, talking about the types of the astigmatism. Now, if I'm talking about the type of astigmatism, please remember the officially there is a three type of astigmatism. They have more over there, right? I already told you five. Then what is a five? Of course, this simple is divided into the two. What? Simple myopic astigmatism or the simple hypermetropic astigmatism. We're going to talk about it. But please remember, if I'm talking about the types of astigmatism, we have the importantly three type of astigmatism. The first one, which is the simple type of astigmatism, just write it down in front of the simple type of astigmatism. There is of course the two focus point. So please remember the one focus point is normal, and other one, it means the second one is myopic or hypermetropic. Now I'm drawing over here. I'm drawing over here. You can see up here, guys, that this is the eye. The patient is having the one focus on the retina. Yes, this black color one focus point, F1 is on the retina. But if I'm talking about the F2, please remember, maybe it will be before the retina. Can you see here? So what is this? This is the simple myopic astigmatism. Why simple myopic astigmatism? One focus normal. You can see here F1 is the normal, and this F2 which I drawn here, this is in the myopia. So that's why this is the simple myopic astigmatism. So the simple means one is normal. Myopic, one is myopic, and this is the having the two focus points. So this is known as your astigmatism. Astigmatism. If it can be happen like that, it can be seen in the hypermetropia also. If it is like that, if it is seen like that, there is a one focus point which is on the retina, this F1, and the second focus point is behind the retina. The second focus point is behind the retina. So this is your F2. So this is what? Simple hypermetropic astigmatism. Simple hypermetropic. Now, if we are talking about this at the treatment part of it, so of course in the treatment part, please remember in the simple myopic astigmatism, of course we use the minus lens, and here we're going to use the plus lenses. But please remember in the cylindrical form. I hope you know about it. What is the mean of cylindrical? Okay, the cylindrical power is having only the power in a one axis. Yes, the cylindrical power we having in the axis on the only on the one axis. The power is only in the one axis. So we're going to use the in this condition we're going to use the cylindrical axis. Yes, we're going to use the cylindrical lenses in this condition. Now the next one we are guys having here. The next one we are having here the compound type of astigmatism. Of course, it will be also divided into the two part. What kind of the two part? Of course, compound myopic astigmatism. The second one is the compound hypermetropic astigmatism. By the word compound, please remember about it. The both of focus point is myopic or hypermetropic. But guys, if both are in the myopia, maybe it is on the same. No, please remember there should be the one focus point should be more than the other one. It means, of course, the focus point 1 is more than the focus point 2. Sir, what you want to say? Listen this part. I'm drawing a special diagram in front of you. So you can see this is the eye, this is the cornea and the sclera. Just a minute. Yes. So this is the first one which is having the myopia. You can see up here. This is the F1. And the second one we are having the behind it. This is also having the myopia. So F1 and F2 both are in the myopia. So you can see this is what? This is your compound myopic astigmatism. So please remember in the simple myopia, right? If I'm giving simple astigmatism, one is normal, second one is based on the name like simple myopic astigmatism. The one is normal, second one is the myopic. In the compound, what is happening? Compound means both of the focus point, the both of the focus point is in the refractive error. So you can see simple myopic astigmatism both are in front of the retina, and the second one simple your compound myopic astigmatism, hypermetropic astigmatism, both of the focus point both of the focus point will be going to meet up behind the retina, behind the retina. So you can see up here, this is the focus point 1, this is the focus point 2. So there is a both focus point is behind the retina. So this is what? Compound hypermetropic astigmatism. Of course, in this condition, what should be your treatment part? Guys, please remember, here we'll use the minus lens, here we'll use the plus lenses. But please remember, there will be not only the cylindrical will be going to help up here, we're going to use spherical plus cylindrical. We're going to use the spherical lenses and we're going to use the cylindrical lenses. The both lenses will be going to used in the compound myopic astigmatism. And the last one, which is the mixed one, which is your rare. And what is the mean of rare? Please remember, one is myopic and other one hypermetropic. Hypermetropic. Yes, is it possible, sir? Yes, is it possible? So I'm drawing you a diagram for you. You can see up here that this is the patient. The one focus point is just before the retina, and the second focus point is behind the retina. F1 and F2, right? So one focus point is in the myopia and the second focus in the hypermetropia. Yes, doctor, the one focus point in the myopia, the second focus point is in the hypermetropia. And in such conditions, guys, please remember, in such conditions, we are going to use the, in this such conditions, we are going to use in the treatment, we are using the minus and plus lenses in spherical and cylindrical form. We are going to use plus lenses also, we are going to use the minus lenses also, and we are going to use the spherical and cylindrical. But please remember here the condition that your cylindrical lenses should be more power than the spherical. So cylindrical power will be more, having the power is the more than the your spherical, right? So this is all about your refractive errors, guys. This is all about your refractive errors which we had talked in this today's session. I hope this session will be going to help you in the your this will be going to help up you in your exam, right? So that's it for the today, and we are going to end this session here only. I had we had the we had the about the talking about the degenerative and the infective of the cornea and the conjunctiva. With that, we talked about the all the optics of the your optics and the refractive errors of the eye in this today's session, right? So this is the all these guys. Please remember, this are all the your important topics, guys. Don't miss such topics. If you didn't had the part one, so please watch the part one and watch this part two also, right? This will be having the all the important topics of for the your 12th January. All right, that's it for today, guys. Yeah, thank you, doctors. That's it for today, right? That's it for today. Goodbye, good luck, and best of luck for you all.